ALL, I think, is witnessing a very interesting time in terms of, again, it's conjugating the laboratory and the clinic in terms of more refined biological stratification at diagnosis, which means different forms of treatment. A typical example is a Philadelphia positive, which has or should be identified at presentation, and these patients should be treated differently with tyrosine kinase inhibitors which target the specific abnormality. So that is the first. And we're learning more with the whole genome sequencing, next generation, new mutations. So the scenario is changing. Second is that it's very clear now that you should, I'm saying should because it depends where you're working, obviously, and the world is very vast, and obviously opportunities are not the same everywhere. But the monitoring of minimal residual disease is now guiding treatment in clinical trials, to an extent that you're even deciding whether or whether not to offer a transplant to a patient based on the fact that the minimal residual disease remains positive or is negative. So this is a major change. So it's not transplant, you can possibly avoid. And then there are more specific treatments that are coming up. There are antibodies that are being developed and always more utilized. Anti-CD20, Rituximab, certainly impacted in one subgroup of ALL, more mature, the Burkitt leukemia, which when I was young was a very unfavorable subgroup. Now they do much better with incorporation of anti-CD20. Now there are more antibodies. Blinatumomab is certainly a very, very interesting compound. It's a bispecific monoclonal antibody, so you target the CD19, the B cell antigen, but then it's an immunotherapy mediated by the CD3, the T lymphocytes. And this is very effective to an extent that we had a symposium where I was even asked to touch upon whether chemo-free could become an option for ALL. You're talking about chemo-free in acute leukemia. So I brought the example of Philadelphia positive ALL, which, just to remind ourselves, was the worst condition you could ever get. Maybe not even only in hematology in general, it was a devastating condition. Now it's obligatory to detect the abnormality immediately, and we're even glad if a patient has ALL, if he or she has a Philadelphia. So I'm old enough to remember what it used to be. It was the worst. An elder you wouldn't even treat. It was just compassionate. Now you can put them into remission even if they're 89, 90. It's amazing this. So you need to define it through the lab and then start an inhibitor. Some people even give it alone, as we do in Italy, others with chemotherapy. But if you give it alone, I'm going to the chemo-free, we've shown that every patient can go into remission. Remission, hematologic, not cured, remission, with no death in induction. So at that point, you may be MRD negative, you may be MRD positive. Then you can come in with a monoclonal antibody. So the next trial, in fact, that should be starting very soon in Italy in a framework for adult ALL, the GMEMA study, will be for all patients Philadelphia positive, 18 age plus, with no upper age limit. So whether you're 70, 80, our oldest patient was 89, and he lived 2.5 years. So he died at 91.5. So you can go up to any age. It'll be with a tyrosine kinase inhibitor, second generation, and then all patients will get Blinatumomab. And the end point will to see how many of these patients can become molecularly negative. So that could be a chemo-free approach. Then we'll see if transplant is still necessary or not. So just to give you an idea, and after all, we've learned a lesson with acute promyelocytic leukemia. It's not lymphoid, another leukemia, where at least two subgroups of patients, the low-risk intermediary, are cured without chemotherapy, without systemic chemotherapy. And now even high risk may get only mild chemotherapy and arsenic and retinoic acid. So it's an evolving field. So that's been, it's a major development. In fact, I may say there was another session on immunotherapy in ALL, another symposium. And that again is opening because obviously antibodies came up, so the anti-CD22, Blinatumomab again, CAR-T, which again, this is very interesting, cumbersome, expensive, toxicity, but this has been modulating. So it's going to become probably more potentially usable. But the data are certainly promising. So I think it's a very exciting time for ALL. A bit less maybe for AML, but ALL certainly now is very exciting. And again, it goes obviously to the issue of how many, let's say, countries in the world can offer this to patients, because that is, again, it's a lot of technology. MRD can't be done everywhere. So we have to combine again lab with the clinic.